Hi, everybody. It's a great pleasure for me to present on the behalf of the International Academy of Clinical Hematology, the post-ASH 2022 Advances in Stem Cell Transplantation. I am Arnon Nagler for Haim Shiba Medical Center, Tel HaShomer, Israel, and the Acute Leukemia Working Party of the ABMT. So first of all, to wish you happy and productive and healthy 2023. So I will start with the education transplantation session that was devoted this year to alternative donors. And the title was, Are Alternative Donors Now Mainstream in Allogeneic Transplant? And the talk that I will present first is with the title In 2022, which is preferred, haploidentical or cord transplant. So we all know that allogeneic transplantation is the treatment of choice for high-risk hematological malignancies. Transplantation from either haplo or cord blood donor is an established alternative for patients who need a transplant but lack an HLA-matched donor. The potential advantages of cord blood transplant are tolerance across HLA barriers, possible lower incidence of chronic GVHD, potent anti-tumor activity, and possible lower relapse rate. Historically, the main disadvantage of cord blood transplant was the cell dose limitation, resulting in delayed engraftment, slow immune reconstitution, high infection rates, long hospitalization, and high early transplant-related mortality. Some of these historical disadvantages of cord blood transplant have been successfully overcome with double unit cord blood transplant and ex vivo expansion cord blood, and I will show you two works that were presented in this ASH. Historically, haploidentical stem cell transplantation have been performed with profound T-cell depletion strategies to reduce alloreactivity due to HLA disparity, but the main limitation were non-engraftment, high infection rate, high transplant-related mortality, and high relapse incidence. Non-T-depleted haplo platform, especially with PTCY, changed the landscape of haplo stem cell transplantation, improving engraftment rates and immune reconstitution, overcoming the historical limitation of T-cell depleted haplo, and I will show you several abstracts that were presented in this ASH for the haplo and PTCY. So the remaining current advantages of haplografts include a shorter time for donor identification, the possibility for repeat stem cell donation, donor lymphocyte infusion, and lower cost. So the haplo started with the soybean agglutinin in patient with SCID, moved to the megadose of CD34 purification in Perugia, and then the Baltimore approach of non-T-depleted haplo with PTCY, and the post-transplant cyclo knocked down the alloreactive T cells and upregulate T regulatory cells. And most of the haplo transplant now, both in the States and in Europe, are being done with non-T-depleted and post-transplant cyclophosphamide. So if we look on this big study on behalf of the Acute Leukemia Working Party, first author is Dr. Ronnie Cheval, in more than 106,000 transplants, 56% of them acute leukemia. When we compared alternative donor transplant to sibling transplantation over 3 periods, you can see that the overall survival and transplantation outcome, both of haplo and of cord blood, were improved over time. And in the cord blood transplant, we see lower relapse rate, and we will talk about it. So if we look now on the activity in Europe, you can see here in the orange curve, the increase in the haploidentical transplant in Europe. Mostly the non-T-depleted haplo was post-transplant cyclo. And the cord blood in Europe is the transplant are being done 50% with single cord blood unit and 50% with double cord blood unit. You can see that the cord blood activity is only 8% of the activity of the allogeneic activity in Europe, more in children, 19% compared to 4% in adult. And you can see in the various categories for transplantation, it's 7% in AML, 9% in ALL, 8% in myeloproliferative disorders and myelodysplastic syndrome, and is only 3% in non-Hodgkin lymphoma. So when we compared the haplo to a single cord blood transplantation with the TBF conditioning, you can see that the 2-year overall survival was better for the haplo transplant, and similarly, the 2-year leukemia-free survival and the GVHD relapse-free survival are better with the haplo transplant because of higher non-relapse mortality with the cord blood and lower engraftment. But when we compare the haplo to double cord blood transplantation, you can see here in the curves that the 2-year overall survival, leukemia-free survival are similar between double cord blood transplantation and non-T-depleted PTCY haplo, but also the non-relapse mortality and the relapse rate are similar. So the most important study in the field is the BMT-CTN 1101 trial, which was 1-to-1 randomization between double cord blood transplant and the Baltimore platform for non-T-depleted haplo with PTCY. The study was planned for 410 patients. However, the recruitment was slow between June 2012 and June 2018. So the study was early terminated in 90% of the planned recruitment. At the end of the day, the hazard ratio for death or progression was higher after cord blood with hazard ratio of 1.3 and p-value of 0.06, but it did not meet the level of significance set for the trial. However, the 2-year overall survival was better for the haploidentical transplant because of lower non-relapse mortality and better engraftment. When the CABMTR did a long-term extended follow-up of the study patient, there was again no difference between haplo and cord blood transplant. But when they combined no trial haplo bone marrow with trial haplo bone marrow, then the 5-year overall survival was better for the haplo compared to the cord blood, and the 5-year non-trial haplo peripheral blood was even better than the non-trial bone marrow. Now, when they look on center effects, centers that had previous experience with haplo had superior outcome with haplo donor, but centers that were not experienced with haplo had similar outcome with haplo bone marrow and double cord blood transplantation. So they conclude that haplo bone marrow with PTCY may be the preferred platform in other centers with limited or no experience with double cord blood transplantation. Now, if we look on a similar Spanish study that compared 22 haplo with PTCY to 23 single cord blood transplantation, now with the TBF conditioning, again, the non-relapse mortality was lower for the haplo transplant, and the GVHD relapse-free survival was better for the haplo-identical transplant. Now, for the PTCY, there is also improvement in the results. So this study, which was just published in BMT, looked on reduced total dose of post-transplant cyclophosphamide in order to reduce the toxicity in the non-T-depleted haplo in patients above the age of 65 or above the age of 60 with cardiac event. And this resulted in improved engraftment, reduced the BK virus hemorrhagic cystitis, and the similar incidence of GVHD and transplantation outcome like the original full dose of post-transplant cyclophosphamide, 100 milligram per kilogram. Now, the cord blood has a potent anti-tumor or anti-leukemic activity, as was shown by this study. So you can see that in comparison to unrelated and mismatch unrelated transplant, there is a reduction in the relapse rate, lower risk of death, and in patients that are MRD positive, better overall survival and reduced relapse rate. And this may be due to the HLA loss phenomenon, which account for 29% of the relapse in the haploidentical transplant and only 2.7% of the relapse in cord blood transplantation, not just because of T-cell number and maturation states, but also because of the haploidentical distribution of mismatched HLH which are on both haplotypes in cord blood transplantation and the same haplotype in haploidentical transplant. So how to overcome the cell limitation of cord blood transplantation? So this is the omidubicel, the nicotinamide transform that resulted in 130-fold expansion of the cord blood CD34, a significant better hematopoietic recovery, both myeloid and platelet, reduction of the risk of infection, and increases the number of days alive in hospital in the first 100 days. The other platform for cord blood expansion is the UM171, which is pyrimidoindole derivatives that are agonists of human hematopoietic stem cell self-renewal, resulting in 28-fold expansion of CD34, which result in a speeding of the engraftment, reduction of days of febrile neutropenia, and the length of hospitalization. So the conclusion of this education talk was that the result of CTN 1101 randomized clinical trial favor haplotransplantation, but both cord blood transplant and haplotransplant are alternative option, and it depends mainly on the center experience and protocols. Future optimization of cord blood transplant should include a better understanding of the HLA barrier, which will hopefully lead to better HLA matching and selection of the optimal cord blood unit. And for the haplo, the future are innovative conditioning protocols that will improve the success rate in advanced age frail patient population, with optimizing the dose and schedule of pro-transplant cyclo to reduce toxicity, improve the anti-GvHD prophylaxis, and reduce relapse rate. And I will show you abstract, oral abstract on all these issues. So if we move now to the oral abstract of this ASH, abstract 267, and of course I could not choose all oral abstract, but a few of them. So this is comparison of the omidubicel to CIBMTR controls all type of donors. So there were 52 patients on omidubicel, so nicotinamide expanded cord blood, compared to match unrelated, mismatch unrelated, haplo, and in non-expanded cord blood, so other donors. And you can see that with the expanded omidubicel cord blood, there is better in red of myeloid engraftment. There is slower in red of platelet engraftment. As for GvHD, acute GvHD 2 to 4, it's higher with the omidubicel, so nicotinamide expanded cord blood, but grade 3 to 4 GvHD is similar. If we look now on chronic GvHD, it's similar of the omidubicel to other donor type. For the non-relapse mortality, again, omidubicel is like other donor type, and you can see here that the non-expanded cord blood in dash gray is skying high, and for the relapse, there is lower relapse rate with the non-expanded cord blood, while with the omidubicel, relapse rate are similar to other donor type. At the end of the day, disease-free survival of the expanded cord blood is like other donor type, and overall survival is also similar between the expanded cord blood and other donor type. So these are the conclusion, and this is really showing that the expanded cord blood overcome the main limitation of the cord blood transplant, which was slower neutrophil and platelet engraftment and high non-relapse mortality. Similarly, abstract 711 compared the other platform for cord blood expansion, the UM171, to its historical control from the CIBMTR, either unexpanded cord blood or unrelated peripheral blood stem cell transplantation. And so you can see here the UM171 cord blood. This is 7-day expansion of purified CD34 from the cord blood. And in parallel, the negative fraction is being infused in order to speed up the immune recovery. And when they did the comparison of the UM171 expanded cord blood to a non-expanded historical control of the CIBMTR cord blood, you could see reduction in the non-relapse mortality, and improvement of the GVHD-free relapse-free survival. And similar, when they compared the UM171 expanded cord blood to a CABMTR peripheral blood, we have reduction in the non-relapse mortality and improvement in the GVHD-free relapse-free survival. And if we look now on the curve, you can see here the nice engraftment with the UM171 cord blood compare a better myeloid engraftment compared to non-expanded cord blood. Similarly, better platelet engraftment compared to non-expanded cord blood, and a reduction, significant reduction in non-relapse mortality, very important in cord blood transplantation, and improvement, a significant improvement on the GVHD-free relapse-free survival. Similarly, when they compared it to a CABMTR unrelated peripheral blood stem cell transplantation, there was no difference in non-relapse mortality, but there was improvement in the progression-free survival and in the composite endpoint of GVHD-free relapse-free survival. So in the plenary session, there were two transplantation abstracts, one autologous transplant, but I will present the allogeneic study, abstract 4, which was presented by Johannes Schettling from Germany. And what they did here, in age of patient with AML, age 18 to 75, that had poor response after the first induction of non-favorable AML or first unrelated relapse, and they had HLA-compatible donor, and they were fit for salvage chemotherapy and allogeneic transplant. They compared a reinduction of remission by the HAM protocol or salvage chemotherapy with RC and mitoxantrone, and then going to a transplantation, or disease control, so watchful waiting, or low dose RC or mitoxantrone, and then the sequential conditioning transplant, so the FLAMSA RIC. And you can see here there were about 139, 137 patients in each study arm. This is well randomized multi-center study. And you could choose the patient characteristic, which I'm not able, due to time restriction, to go in. And you can see at the end of the day, the leukemia-free survival and the overall survival are no different between the group of reinduction or induction of remission compared to the group of disease control. And in the group of disease control, there were less adverse events and shorter hospitalization. So the author concludes that patients with poor response after first induction therapy or relapse AML do not benefit from salvage chemotherapy with high-dose cytarabine plus anthracycline prior to allogeneic transplant, that watchful waiting and sequential conditioning prior to allo result in comparable CR rates and overall survival, and maybe the preferred option whenever a stem cell donor is ready available. And patients with the disease control spend less time in hospital, so 19 days versus 42 days with disease control compared to a remission induction, and experience fewer adverse events of more than grade 3. So what about patient prognostication and mutation? This is abstract 302 that was presented by Professor Ali Bazarbachi from Beirut on behalf of the Acute Leukemia Working Party of the EBMT. And what we look here is the somatic mutation according to the 2022 LN risk. You have the list of mutation here. And we looked on the effect of this somatic mutation on transplantation outcome. Overall, we had 362 AML patients with available pre-transplant next generation sequencing, and you can see the patient characteristic. Again, no time to go into details. And these are the list of mutations. So the most frequent mutation was, as published before, the DNMT3A, 33%, then the FLT3, NPM1, TET2, and RANKS1. And we could identify two independent groups of occurring mutation. One group was the DNMT3 T3A, NPM1, and FLT3. And the other group was the ASXL1, SRSF2, and RANKS1. And so when we look on this most frequent mutation, patient with this mutation, we had 145 patients that we had data of these 6 mutations. You can see the patient characteristic, mostly intermediate cytogenetic. 35% of them were transplanted from sibling, and then 22 from haplo, mostly peripheral blood and myeloablative conditioning. And so the results are in median follow-up of 2.7 years. In this patient in which we looked for this 6 mutation was 2-year overall survival of 67.6% and progression-free survival of 58%. And when we looked on the outcome of the transplantation according to the mutation or group of mutation, the best result was in 32 patients with NPM1 with 81.1% 2-year overall survival and 71.9% 2-year leukemia-free survival. Then the patient with FLT3 and or DNMT3A 35 patient with 63.7% 2-year overall survival and 48.8% 2-year leukemia-free survival. Then patient with ASXL1 or RANKS1 or the SRSF2 26 patient with 76.9% 2-year overall survival and 69.2% leukemia-free survival. And the worst was patient with the no mutation out of the 6, so the negative for all 52 patients with 57 2-year overall survival and 49.5% 2-year leukemia-free survival. So we could identify 2 independent groups of co-occurrent mutation. One, the group 1 with DNM, T3A, NPM1, and FLT3, and the other with AXL1, SRSF2, and RANKS1. And the best result was in patient with NPM1 mutation to be followed by patient with RANKS and or ASXL1 and or SRSF2 mutation, and the worst with all 6 gain and mutation. So what we do with this mutation is, of course, to have drugs, targeted drug against the mutation, and this is one example of this from MD Anderson, abstract 376, with the menin inhibitor, revumenib, which is against the patient in relapsed refractory AML patient with the KMT2A rearrange or NPM1 mutation. And this is the mode of action of the revumenib, and we, of course, don't have time to go into it. And this was the Augment 101 study, escalated study, as you can see here. And overall, they have 68 patients with the patient characteristics are listed in this slide. Overall, they had 30% in relapsed refractory AML with the revumenib inhibitor, with CR or CRh. Over 20% of the patient achieved CR, and the overall response rate was 53%. And this is the water flow of the patient. You can see that the median time to response was 1.9 months. The median duration of response was 9.1 months. And the median overall survival was 7 months. And so revumenib resulted in deep durable responses in heavily pretreated relapsed refractory KMT2AR and NPM1 patient and demonstrated a clinically manageable safety profile. Now, 12 of these patients underwent transplantation, and they were reported in abstract 367. And so you can see 12 patients out of this Augment 101 study went undergo transplantation, and 3 of them received a maintenance therapy. So out of the 12 patients that underwent transplant, 9 achieved remission, 2 relapsed, and 1 died. And these are the 12 patient characteristics. These are the water flow of this patient. So 4 patients had remission lasting at least 1 year without additional maintenance therapy. And again, the conclusion was that revumenib result in deep responses in heavily pretreated relapsed refractory KMT2AR and NPM1 acute leukemia. So this is example how the future of AML patient with drug design and mutation against the specific mutation will go. 2 of these patients receive maintenance therapy post-transplant with the menin inhibitor. One is 1 year post-transplant MRD negative, and the other one relapsed 4.5 months after in remission. And so this is the conclusion for the overall study, and the safety profile was nice. So what about induction? So this is abstract 988 that was presented again by Alexandros Spinionidis for the behalf of the acute leukemia, and this is validation of the transplant conditioning intensity that we reported a few years ago. So the way that we establish this transplant conditioning index is by taking all the components of the conditioning and rank them as either low, intermediate, or high. You can see here, for instance, for the TBI or the busulfan, what is low, intermediate, and high, and then give it a score. And so if it's total conditioning index score 1 till 2, it's reduced intensity conditioning, so low TCI. If it's high TCI, 4 to 6 score, it's myeloablative conditioning in green. And if it in between 2.5 till 3.5, this is reduced toxicity conditioning. And you can see that it nicely separates the 3 group of patients and doing even better in patients between the age of 55 to 65. Now, in the current abstract, we had a validation course, a more recent transplant between 2018 and 2021, and an age up to the 75. And you can see here the separation very nice. With the low TCI 1.2, it's 48% of the patient, and almost all is reduced intensity conditioning. The high 4 to 6 is only 4% of the patient because, of course, elderly patient, and this is myeloablative. And in between 2.5 to 3.5, it's 48% of the patient, and this is reduced, what's called reduced toxicity. And so you can see here now the cohort or 3 cohort of patients, and you can see that in the low TCI, obviously we have more patients with lower Karnofsky score or high comorbidities or high unrelated transplant. And the TCI predict not just early mortality, early non-relapse mortality, but total non-relapse mortality, and also, as you can see here in the multivariant analysis, relapse. So the TCI index a stratified regimen according to early non-relapse mortality, and relapse, and is the most important determinant of early non-relapse mortality, with nearly doubling risk for each TCI group. And TCI is a strong and independent predictor both for overall non-relapse mortality and relapse. And of course, this need further validation in an unrelated cohort of patients. Now, what about the dose of IV busulfax? And this is abstract 985 that were presented by Professor Renier de Villiers from the Didi Blaise group in Marseille. So this group published long ago that with 2 days of busulfax in elderly patients, they have low non-relapse mortality and long-term preserved quality of life, which is extremely important. You can see here in red the various components of the quality of life. But the relapse rate, as you can see here in blues, was high. And the question was that whether by giving more IV busulfax, they can reduce relapses. So this is well randomized study, multi-center in France, between 2 days of busulfan and increasing the dose of busulfan in the conditioning for 3 days and 4 days. Overall, at the end of the day, they had 61 patients that received 2 days of busulfan, 56 patients that received 3 days of busulfan, and 35 patients that received 4 doses of busulfan. And this arm was stopped earlier because very high transplant-related mortality. And so you can see sort of the grade 2 and 4 acute GVHD was lower with 2 days of busulfan. And for grade 3 to 4, it was the highest with the 4 days of busulfan. As for chronic GVHD and severe or moderate chronic GVHD, the dose of busulfan did not matter. Non-relapse mortality was very high with 4 days of busulfan in black, and this was why this study arm was early terminated. But there was no difference in relapse. So the trial failed to show that increasing the dose of busulfan to 3 days or 4 days reduced relapses. And you can see here the progression-free survival, overall survival, was best in this elderly patient with 2 days of busulfan. And this was confirmed in multivariant analysis, both for the GVHD, acute and chronic, non-relapse mortality, relapse, progression-free survival, and overall survival. So reduced toxicity with fludarabine and 3 days or 4 days of busulfan failed to improve 2-year progression-free survival after allogeneic transplant compared to 2 days of busulfan. 4 days of busulfan is not feasible in older patients in the present form because of extra toxicity and non-relapse mortality, and no benefit in disease control was shown with using higher dose of busulfan. Another conditioning abstract was abstract 871 that was presented by Jesus Duque Afonso from the Professor Finke group that compared fludarabine melphalan to 2 fludarabine melphalan protocols, but with addition of another alkylating agent to melphalan, either BCNU and tiotepa. Now, the dose of melphalan in the flu-mel conditioning was 140, while the dose of melphalan in the 2 alkylating agent protocol was 100 milligrams. So these are the hypothesis and study design, and overall you can see here the patient characteristic, 1,139 patients with the flu melphalan and 412 with the 2 alkylating agent protocol. And in the end of the day, the overall survival and leukemia-free survival was better with the 2 alkylating protocols compared to the flu melphalan. And this was because of reduction in non-relapse mortality, while the relapse incidence did not differ. And this was confirmed, as you can see here, by multivariant analysis. So the conclusion was that despite older age, worse Karnofsky score, and receiving more often unrelated donors, patients treated with 2 alkylating agent conditioning showed improved overall survival, leukemia-free survival, mainly due to the lower non-relapse mortality, but again, the lower dose of melphalan in the 2 alkylating agent may have to do something with this result. Now we will move to haploidentical transplant and post-transplant cyclo. And this is abstract 369 from the CIBMTR. Last author was Cutler Corey. And it looked on the late graft failure in MDS and acute leukemia, comparing haplo to unrelated transplant, because there is data on more non-engraftment or late graft failure in the haploidentical transplant. So these are the objective of the study, and this is the cohort of the study. They end up with 1,151 haplo and 185 unrelated transplants. And these are, again, a very busy slide with patient characteristics that we cannot detail in this post-ASH transplantation on behalf of the International Academy of Clinical Hematology. But the important is that there was no difference in graft failure between haplo and unrelated transplant with post-transplant cyclo, but there was higher mortality in the haplo with post-transplant cyclo, and the graft failure contribute to the higher mortality in the with haplo compared to unrelated transplant with PTCY. When they look on the effect of haplo versus MAD on graft failure, again you see that there is no difference in graft failure between MAD PTCY and haplo PTCY, and there is higher graft failure in patients with MDS and in transplant between 2015 and 2018. When they look on the effect of haplo versus MAD on overall survival, here you can see that there higher mortality with haplo in patients above the age of 55, in patients with high disease risk index, high comorbidities, and in ALL. And in the multivariant analysis, the 2-year graft failure are 6.5 for the haplo-PTCY and 5.9% in the unrelated PCY, still higher than what we see usually with methotrexate cyclosporin A, and the 2-year overall survival is better with the unrelated PTCY, 69% compared to 56% with the haplo PTCY. So there is no significant difference in left graft failure after transplant with haplo versus unrelated donor. MDS is associated with excess risk of graft failure, and rate of late graft failure appear higher than in traditional tacrolimus methotrexate. The overall mortality is higher for haplo compared to MAD, and the risk factors are age, disease risk, and the comorbidity score, and the graft failure, regardless of donor type, is associated with excess mortality. Now, how can we maybe improve the GVHD prophylaxis or incidence after haplo? So maybe by combining the post-transplant cyclo with GTLA4 abatacept that was just approved for graft versus host disease, and combining it with short course of tacrolimus, the CAS, so-called CAS GVHD prophylaxis. This is abstract 3396. And you can see the design. So PTCY is 50 milligram per kilogram IV on days +3, +3, and +4. Abatacept 10 milligram per kilogram IV on day +5, +14, and +28. And tacrolimus starting at 0.02 milligram per kilogram on day 5, then adjusted to the blood level, and then played to taper after 60 days over 4 weeks. And so they had 46 patients, and you can see the results are really nice, but short follow-up with grade 2 to 4 GVHD of 18%, grade 3 to 4 of 4.5%, chronic GVHD is 12.5%, no patient died from GVHD, and no patient with steroid refractory GVHD. Relapse-free survival, overall survival, and GRFS are very high, but again, short follow-up. Transplant-related mortality is low, 4.4%, and the relapse incidence is also a low, 7.3%. And of course, and the immune reconstitution, as you can see here, is very good. And of course, this needs to be confirmed in a larger group of patients. So another option for reducing GVHD and improving result in the haplo transplant, even without PTCY, is the graft engineer, the ORSA-Q, which was abstract 769, which is the graft engineering and giving T-regulatory cells on day of transplant and day 1, and then giving T-con, so the regular T cells. So in order to reduce GVHD and still keep the graft versus leukemia and graft versus infection effect. So this is the study design. So this cohort of patients is 26 haplo patients that again did not receive PTCY for GVHD prophylaxis, and you can see the grade 2 or more GVHD is very low, 8%, grade 3 acute GVHD is very low, 5%, and then the chronic GVHD is very low compared to historical control of 24 to 33%. And also the GVHD and relapse-free survival is really very impressive. And again, the overall survival, but the follow-up is short. So they also looked on the ORCA-T in patients that received the sibling and unrelated transplantation. And so again, this is the infusion of T regulatory cells, and then infusion of regular T cells, and vein to vein is 72 days. And you can see here they compared, first of all, 151 patients that received either unrelated or sibling transplant with ORSA-T compared to the CIBMTR. And you can see that the results are better. So GVHD relapse-free survival is 71 year, 70% with the ORSA-T compared to 21 with the CIBMTR. Non-relapse mortality is only 4% compared to 10%, and the overall survival is 88% compared to 68%. Really impressive, and when we look on the graph, really impressive. So the relapse-free survival is 87%, non-relapse mortality is 0. Acute and chronic GVHD are very low, and also very low incidence of infection. So graph manipulation may be a way to go, both in haploidentical transplant, but also in the sibling and unrelated transplant, keeping the graft versus leukemia and graft versus infection, and very low incidence to GVHD. And they also show a very nice immune reconstitution. This is very nice study with all T cell subset, with memory T cell, with track of the thymus and repertoire, and showing how this immune reconstitution is very nicely occurring with the graft engineering and the ORCA-1. One of the most important studies, to my opinion, was abstract 114 from Minnesota, in which they looked on a patient with 8 out of 8 or 7 out of 8 unrelated transplant with myeloablative conditioning, comparing post-transplant cyclophosphamide with tacrolimus and MMF compared to cyclosporine methotrexate. And so, what they looked at, of course, is acute GVHD, chronic GVHD, overall survival, and relapse in 282 patients. And with the PTCY, there is lower incidence of chronic GVHD requiring immunosuppression, so only 4% compared to 34% with the cyclosporine and methotrexate. Similarly, for acute GVHD, both grade 2 to 4 and 3 to 4, there is lower incidence with the PTCY, tacrolimus, and MMF compared to the conventional cyclosporine methotrexate. And the non-relapse mortality is significantly lower, 10% compared to 19 with the historical cyclosporine A and methotrexate, and the relapse and progression is not different. So lower incidence of GVHD, but not lower incidence of graft versus leukemia effect, and the overall survival and the composite endpoint of GVHD relapse-free survival are better with the PTCY, tacrolimus, MMF, and 8 out of 8 or 7 out of 8 unrelated transplant compared to the cyclosporine methotrexate. And this is the confirmation of this result in multivariant analysis. So they conclude that PTCY, tacrolimus, MMF reduce grade 3 to 4 acute GVHD, 2 chronic GVHD, and improve overall survival compared to historical control. However, there was high GI tract toxicity, and 3/4 of the patient received EPN. So another way to reduce graft versus host disease, which is of course a main obstacle for 30 or 40 years for successful allogeneic transplant, is the ASH22 presented in abstract 774 by Chen In Bin from Massachusetts. And this is the RGI-2001 contain the active moiety of the alpha-gal cell, which is bind to the CD1D receptor of invariant natural killer cells, and then by production of cytokine upregulate T regulatory cells. So they looked on 49 patients, and you can see here the patient characteristic and the graft source and the donor type. So this is either identical sibling or unrelated transplant. And you can see the outcome again, grade 2 to 4 GVHD is 20%, grade 3 to 4 very low, 4%. Overall survival at day 100 is 93.9%. And you can see here the nice data for GVHD relapse-free survival, encouraging result, but still small group of patients, 49 patients, and short follow-up. So these are the impressive curves of the overall survival and in black, and the grade 2 to 4 acute GVHD free survival in red. And you can see this was also very safe. It was quite safe with very few treatment-related adverse event, more than 4%. And so the RGI-2001 showed promising potential efficacy when added to standard GVHD prophylaxis of calcineurin inhibitor plus methotrexate after myeloablative hematopoietic stem cell transplantation. Another important study how to reduce GVHD is abstract 112 with the pooled fecal allogeneic microbiotherapy presented by Professor Muhammad Moti and Florent Mellard from Paris, France. So this is 3 enemas, 150 milliliter each bag within 2 weeks. And they had 81 patients. You can see here the patient characteristic. 84% of the patients were steroid resistant, and 16% of the patients were steroid dependent. 51% of the patients had grade 3 GVHD, and 38 had grade 4. 59% had only GI tract GVHD, and 23 had both GI and skin GVHD. A number of lines of prior therapy are 2 up to 6. 100% of the patients received the steroid, and 81% received ruxolitinib. And you can see that the overall response rate was 56%, with 37% of the patients achieved CR and 14% very good PR. And the results were better in steroid-dependent GVHD, with the overall response rates of 92% and 69% complete response, compared to steroid refractory GVHD, 49% overall response, but very impressive data, and 31% complete response. And if we look on patients that were refractory to ruxolitinib, so 56% overall response and 38% CR. So very impressive data, and these are the curves. So you see here the overall survival, and patients that respond to this MA-T013 fecal transplantation had a better response. And this is the overall survival in steroid or ruxolitinib refractory, and again in red, the patient that respond, the overall survival is 74, and this is unprecedented. It was safe, and only 2 patients had the non-pathogenic commensal bacteria associated with infection in vet. So this, the authors conclude by the proposed mechanism for the MAAT013 fecal transplantation, that it restored microbiome diversity, regenerate gut barrier protective effect, and significantly curbs inflammation, and improved GVHD in steroid refractory and also ruxolitinib refractory patients. So another important complication of transplantation is, of course, VOD, and this study show real-life defibrotide treatment in analyzing pooled analysis of 2 real-life studies with defibrotide. One was the fibrotide France, and the other one was the EBMT PAS study presented by Professor Muhammad Moti. In both studies, in different primary endpoint and secondary, they look on day 100 survival in patients with veno-occlusive disease that received the fibrotide, and also on adverse effect. And you can see here the patient characteristic. So the analysis include 108 patients with non-severe VOD and 302 patients with severe VOD. And they looked on the response, and among the 300 patients who achieved VOD resolution, 208 had severe VOD, and 991 had non-severe VOD. And what they looked is the length of the fibrotide treatment, TIL resolution, and in patients that had severe VOD, it was longer. So for instance, 36% of the patients with severe VOD required more than 28 of the fibrotide treatment, and 65 required more than 21 days to achieve resolution, while in the non-severe GVHD, only 23 required more than 28 days, and only 35% and 35 required less than 21 days. But whatever the duration, patients that respond to the fibrotide had better day 100 overall survival, as you can see here in the bars of severe VOD and non-severe VOD. And importantly, there was no more side effect in patients that received longer treatment of the fibrotide, and only 25% of the patients had therapy-related severe adverse event. So very encouraging. And the author concludes that in this pooled analysis study of the fibrotide France and EBMT PAS, real life, the fibrotide for veno-occlusive disease, a higher percentage of patients with severe VOD require more than 21 days of the fibrotide treatment. But the most important is that regardless of the severity, day 100 survival was higher in patients that achieved resolution of the VOD, and the safety profile was similar between patients that received longer period of fibrotide to lower, and also it was similar to the reported study. So the last abstract that I will present is abstract 377 from Dana Farber about maintenance therapy. So this is the group published previously adding venetoclax, the flu, and 2 days of busulfan reduced intensity conditioning in blood advance in 2021, and now they report the maintenance part of the study. So just to remind us all, this is escalating dose of venetoclax, 200 milligram or 400 milligram, and the chosen for the expanded phase was 400 milligram QD on day -8 to -2. And you can see here the published curves of the 22 patients, and the overall survival, 1 year, 67%, and the progression-free survival, 53%. And they did a very thorough longitudinal genetic MRD assessment by ultrasensitive duplex, and among the 18 genetic MRD positive patients, 6 of the 9 relapses and had persistent MRD at day 28, day 100, and 9 of 18 that achieved MRD negativity, only 3 relapsed. So now they report the cohort of patients that in high-risk MDS and AML received maintenance post-transplant therapy was azacitidine, and 2 doses of venetoclax either for 8 cycles or for 12 cycles. You can see here the pre-transplant mutation, and this treatment, maintenance therapy, was tolerable with very few side effect, was safe. And the end of the day, you can see here the median overall survival was 19 months, and the median progression-free survival was 16.5 months. And if you look only on the 22 patients that received the maintenance therapy, the 1 year overall survival was 82%, and the 1 year relapse rate was 36%. So they conclude that randomized trial is needed to confirm the role of venetoclax modified reduced intensity conditioning for transplantation and prophylactic maintenance with venetoclax 400 on day 1 to 14 and other 36 milligram per meter square on day 1 to 5 is feasible, safe, and tolerable. And this is important study because we know that relapse is one of the main obstacles for allogeneic transplantation. So with this, I would like to thank all the colleagues, long list of colleagues that gave me slides and their ASH presentation for this post-ASH summary on behalf of the International Academy of Clinical Hematology, and this is unpublished data, so I really appreciate and thank them all. And I will be happy now to take a question, and I'm sure that there are a lot of questions for this various abstracts that in the various aspects of allogeneic stem cell transplantation, showing how the field is fast moving and improving, both for the conditioning, GVHD complication, VOD complication, and also the relapse post-allogeneic transplantation. And thank you. So thank you very much. It was more than the usual post-webinar of the International Academy of Clinical Hematology because ASH, as we know, it's very extensive and a lot of new stuff was presented there, including in transplantation. But of course, we heard last week from Professor Moti on myeloma and other disease, leukemia and disease category. So I first apologize that I could not present more of the abstract. I guess that I presented like 15 abstracts, but try to cover most of the field of transplantation. And of course, there are many questions. Luckily enough, as always, we have a few hundred people that join us this evening, or noon or morning, depend where you are. And there are a lot of questions, and I will try to answer them, but of course, cannot cover all the fields, and everybody is invited to send me the question by email, and I will try to answer. So many questions, again, about the haploidentical transplantation. And first of all, is there still a role for cord blood transplantation? This is very important and practical patient because we know that I didn't have time to go into it, but most of the world, the main alternative donor transplant today is haploidentical transplant, thanks to the non-T-depleted and the post-transplant cyclophosphamide, which is not just easy, but with very good outcomes and results. And it's very hard to compete with it. And therefore, both in Europe and in the States and in China, of course, most of the alternative donor transplant are haploidentical transplantation. The only continent or country in which the haploidentical cord blood transplant is increasing is in Japan. In Japan, about 25% of the allogeneic activity is still with cord blood. And of course, as we've seen from this ASH, and we know that the cord blood transplantation in pediatric is more than a higher percentage of the transplant than in adult. But I think that in spite of the great results with haploidentical transplant and post-transplant cyclo, I think that as you have seen, there is really improvement in the cord blood transplant because as we have seen, the anti-tumor effect of cord blood is strong. It was shown in patients with MRD positive and from the Seattle, and now there is a paper that was submitted from UK in pediatric AML and MDS that showed the same data. and there are blood papers about specific CD4 cytotoxic cells from the cord blood that even are expanded after granulocyte transfusion. So the graft versus leukemia effect is very strong, and the main problem with cord blood transplant was the cell dose. And you have seen two techniques how to overcome, in phase 3 studies that is very close to be, registered, and cell therapy that will be registered in hundreds of patients, showing the advantage of ex vivo expanded of cord blood, and also the UM171. So I think that the cord blood is still a valuable option, and I'm sure that there is patients that can benefit from cord blood, and maybe with this expanded cord blood, after it will be approved by the FDA and so on, we will see more patients that are getting cord blood transplantation. But of course, the main alternative type of transplant, including in our department, is haploidentical transplant. Then there is here a question about, thank you, Professor Nagler, would you use AZA-VEN maintenance in all AML patient post-allo, excluding FLT3 mutation? So I think that not just in transplant, but mainly in leukemia, we've seen multiple papers, especially from MD Anderson, with double and triple drugs, and narrowing the importance of a transplant unless you are young and fit. But I will say it for the elderly patient, showing how you can combine the venetoclax with azacitidine and the third drug with really fascinating, marvelous results. I think that venetoclax is becoming a very important drug in leukemia therapy, and was happy to see at ASH this work that they combined venetoclax with the old or the conventional conditioning for transplant, and also maintenance therapy. So I think we should give to the all, of course, to all high-risk patients that we are transplanting, maintenance therapy. Until now, we had only sorafenib and FLT3 inhibitors. And so I think that we started, again from the Lima et al. With Vidaza post-transplant, and now the combination with venetoclax. Of course, maintenance therapy, the post-transplant is with more toxicity, and usually with historically with other mode of maintenance therapy post-transplant, you need to reduce the dose because bone marrow is fragile from pancytopenia and other toxic or more side effects. Personally, I think that it looked to me, but still it's in clinical trial, and we need to keep it in clinical trial. But the data that was presented in the last abstract from Harvard are very interesting. And another thing important here was the MRD monitoring. So we all know that the importance of MRD pre-transplantation, that it predicts outcome, but we all usually don't give more induction therapy, at least in AML, in order to achieve MRD negativity. And this is because we maybe don't have the belindomab or inotuzumab of ALL in AML. And the drugs that we can give are maybe toxic, and you saw the plenary session showing that even provocative, maybe the CR pre-transplant and even the MRD negativity pre-transplant is not so important, although there was criticism about, giving, in this ASH, there was question that this is not the way to go in the state, and usually patients get Vidaza venetoclax or something in order to achieve the CR if they are not in CR after first induction. But when we do MRD post-transplant, I think it's extremely important, although not easy to interpret it because of the chimerism. But if we are MRD positive, for sure, as was shown, the risk of relapse is higher, and then we should give therapy. And I would go for ASA venetoclax and preemptive therapy post-transplant, and we will not discuss now prophylactic or preemptive. And then there is a question for another colleague. What do you think about the DKMS study? Is salvage therapy for relapsed refractory ALL really absolute? What do you think about the role of MRD before allogeneic? So I just discussed it before I saw this question. I think that MRD before transplant is extremely important, but we are not yet in AML in a situation in which and the depth of response, and this was shown in many papers, that if you are MRD negative, you are less relapsed, better leukemia-free survival, overall survival, GRFS. However, we are not in the position to give more course of chemotherapy in order to get MRD negativity pre-transplant. But of course, if we have the blina of ALL in AML, we would give it, or many people will give it. So I think it's important pre-transplant. And as for the salvage therapy, there is criticism for this. Not everybody agree. That you should go directly to Flamza and reduce intensity conditioning. This is done in Germany, and this study showed it in well-designed randomized study, even less side effects. So it's hard to argue with randomized study. We always preach for a two-arm study and a well-randomized study, and then when there is the result of such a study, we don't want all of us to change it. But I think that this is important study. This is not, I would say, the strategy in our department, in many departments in the world, but we need, I think, to respect a two-arm study. Of course, there are a deficiency of this study, as I discussed, and I don't know if this is for all the patients and the total and only solution, but yes, it's important study. So the other question is about GVHD. Of course, we had first of all, post-transplant cyclo revolutionized the field, and I will guess it's moving to be not yet, but it's getting closer to be the treatment, optimal treatment in unrelated transplant, not just in haploidentical transplant. I'm very careful, but it was best of abstract, and I show you the Minnesota study. So I think that we are getting there. Should we combine it with abatacept combination for GVHD prophylaxis going to fair in future? I think that the data that I've shown you are very impressive. I think should be way to improve on the original pioneered and 100 milligram post-transplant cyclo. One was the Bacigalupo changing the day from 3 to 4 to 3-5, and starting the immunosuppression at day 0. But the other way that I showed you was the French study online now in BMT, reducing the dose of post-transplant cyclo from 100 to 80 milligram, improving engraftment and reducing hemorrhagic cystitis with no price for relapse or the similar GVHD. And I think that the data with combination with abatacept are interesting. This was the only, poster, not oral, that I presented because the data are interesting. I think that the results are very good, extremely. Of course, we need more patients, we need more follow-up, but if the toxicity will be like in the abstract that I presented you, low toxicity, and the results will continue. So I'm for this protocol. And then we have a question here. What is the lowest effective dose of PTCY in haplo-identical T-cell replete graft? So I don't know the lower dose of PTCY. I know this study that was mentioned with 80 milligram. I know that Professor Pazweg also published in BMT reducing the dose of post-transplant cyclo. So we looked on the various days and various immunosuppression, and also lowering the dose. I'm not sure we can go much lower, but we have no data for it. The toxicity of PTCY is not so. There is some interesting data in this ASH that PTCY is with late relapses, with also late CMV infections. I know, we need more data and more studies. But I think that the data currently with PTCYs are extremely impressive, reducing drastically transplant-related mortality and chronic GVHD, and no higher relapse. So I think that this invention is really, moving the field of transplant, actually a total revolution in GVHD therapy, which we looked for so many years, besides the 3 drugs approved for chronic GVHD. So there are many more questions, and of course, many more things to be discussed, including the graph engineering, very interesting data with the T-con and T regulatory cells, no PTCY, very nice data that should be confirmed, short follow-up, but very impressive for me. And the data are extremely important of veno-occlusive disease, one of the really lethal complications in transplantation, and really the fibrotide, we all know in our own department, saving life. And here there was data that, you can safely give 28 days or more the fibrotide with no toxicity, low toxicity, and the results are very nice. So, there is a lot of more we need to do, or can hopefully do with the fibrotide. And I don't go into the question of prevention because of the black box in nobody understands why, in EMEA and so on. But, the result with the fibrotide, really the VOD is another lethal complication in transplant, and the fibrotide really is saving the life of patients. So I hope that you enjoyed this post-ASH webinar on behalf of the International Academy for Clinical Hematology, and there are many more to come from the ASH on CAR and on AML and other disease categories. And I wish you a restful evening or day, and bye-bye. Thank you.